Good afternoon, ladies and gentlemen. I want to present you my patient with recurrent pyelonephritis after kidney transplantation and ask you to find with us some solution for him. This one, okay. I'm so sorry. This boy was without any problems until age of 4 years. Only common infection appeared, and at 4 years of age, he had acute pyelonephritis with acute kidney injury that needed one acute hemodialysis. On UCG was found bilateral megaureter and after that was persistent alteration of renal function, urine bladder dysfunction, and that is why he was provided bilateral nephrostomy and later vesicostomy. And due to detrusor hyperreactivity, intradetrusor botulinum toxin was installed. At 5 years of age, non-neurogenic bladder dysfunction was in progress, and that is why the urologist provided him continent appendic vesicostomy. In 11 of at 11 years of age, he was catheterized through the urethra 8 times per a day and 2 times per a night. He was on oxybutynin therapy and on cystometry was without signs of urine bladder hyperreactivity, and on mictural ureterogram, urine bladder was without pseudodiverticula, and he had large post-micturation residual volume and free urethra. At 12 years of age, urine bladder hyperactivity was worsening, and on cystometry was only minor contraction in filling per 40 milliliters per minute, and gradual elevation of intravesical pressure in terminated volume 232 milliliters. At 13 years of age, the puncture epicystostomy was provided to permanent urine derivation into the urinary bag. And in 14 years of age, the continent appendicovesicostomy was done, and maximal bladder volume was 350 milliliters. That standard volume can be up to 500 milliliters. We prepared him for kidney transplantation and putting to the waiting list. We provide again MCUG with atypical urine bladder configuration and with thick wall. No vesicoureteral reflux was found, and renal function gradually progressed to end-stage renal disease. In objective findings in this boy, we have to say that he has very severe obesity. BMI was between 36 and 39, and you can imagine the fat abdomen in this boy. And we put him to waiting list at age of 15 years, and it was at November last year. He was dialyzed on other center, not in our hospital, and hemodialysis was started on May this year. Now you can see a typical sharp of his urinary bladder on MCUG. And we provide the urodynamic study with filling 40 milliliters per minute. The first first sensation to voiding was at 229 milliliters and finishing and 337 milliliters. So there was no evidence of the trusor hyperreactivity, and intravesical pressure was up to 17 aqua centimeters. We can summarize now status before kidney transplantation and stage renal disease to diagnosis obstructive uropathy, urethral stenosis in pars membranacea with no evidence of posterior urethral valve, continent appendicovesicostomy with catheterization every 2 hours per day and 2 times per night, normal bladder pressure up to 17 aqua centimeters, and maximal capacity of urinary bladder was 334 milliliters. No passive vesicoureteral reflux was found, and on UCG was normal findings on calicopelvic system, and this boy has no urinary tract infection to this time, and he has only severe obesity. Kidney transplantation was done this year in June with normal post-operative course, only with gradual development of graft function. We had permanent derivation of urine through appendicovesicostomy. In his regimen, immunosuppressive therapy was prednisone, mycophenolate, tacrolimus, and his creatinine baseline was between 90 and 100 micromole per liter. We have complication with posterior reversible encephalopathy syndrome, and in the end of his hospitalization was wound dehiscence where the skin culture was positive for Klebsiella pneumonia, ESBL positive. ATB therapy was metronidazole used, and resuture was done in the 30th day after transplantation. Post-transplantation course, we have complicated with first graft pyelonephritis. It was in the beginning of the August. In urine culture was Klebsiella pneumonia ESBL positive. We treated him with amoxicillin, cleveland, and piperacillin due to sensitivity, and his creatinine was not 14 but 140 micromole per liter. Second graft pyelonephritis was 3 weeks later, again with Klebsiella pneumonia and Enterococcus faecalis. His CRP was 213, and creatinine was elevated above his baseline of to 154 micromole per liter. We do cystography with findings passive vesicoureteral reflux into graft 3 and 4 degrees, and maximal bladder filling was only 265 milliliters, and there was sign of slight ureteral dilatation to 5 and 6 milliliters. We decided to provide him cystoscopy with installation of Urodex, but our urologist couldn't find the place where is the ureter installed to bladder wall, and only that it wasn't successful. And on cystoscopy, we found only trabeculate bladder with pseudodiverticula. We provide him urodynamic study with maximal load 240 milliliters and pressures about 18 centimeters, aqua centimeters, and maximal was 35 centimeters. And solution for this was to install him Foley catheter for permanent urine derivation through the appendicovesicostomy and change it every 1 week. And after that, third graft pyelonephritis was in the end of September with again Klebsiella pneumonia and very high alteration of renal function. His creatinine was 457 micromole per liter, urea 27. We treated him again meropenem because of sensitivity. It was only antibiotics that Klebsiella was sensitive, and the fourth graft pyelonephritis was during the November. And again, we have Klebsiella pneumonia positivity, and because we control him very often, we started to treat him very early, and CRP was only 43, and creatinine was normal. Post-transplant status we can summarize as for pyelonephritis with Klebsiella pneumonia, ESBL positive, vesicoureteral reflux, third and fourth grades into the graft ureter, maximal bladder volume very low, 240 milliliters. He has trabeculite bladder with pseudodiverticula, urethral stenosis, and free drainage from ureter into the bladder. Creatinine baseline is increased from 100 to 110 and 120 micromole per liter. And my question is, what is urological solution for this patient to do incontinent vesicostomy or urine bladder augmentation or other solution, and what is the way how eradicate Klebsiella pneumonia in this patient? Thank you.
Thank you very much. Quite a complex case. And just to understand, the native kidneys are still in, right? The native kidneys are still in?
Yeah.
And when you say appendicovesicostomy, do you mean like a Mitrofanov?
Mitrofanov.
Fine. Okay. Okay, shall I open it to our audiences first? Participants? Anybody? Unfortunately, we lost Johnny, who's our urologist, but I'm sure Nisa will have a few ideas. I have one or two.
All right. Is the child regularly catheterizing 3-4 times a day?
Yeah, he is on a permanent derivation with Foley catheter, whole day and whole night, and we change it, and we change the catheter every 1 week.
Okay,
it's very difficult because he has very fat abdomen, and it isn't good.
So I'd probably have him on intermittent catheterization every 3 hours and drainage overnight. And then I think I'd take out both kidneys and ureters. I think he's getting reflux up into those systems, and that's just causing a reservoir of urine which is infected. That's giving the pyelonephritis. So that's where I'd start.
Thank you.
I thought in earlier on there was some reflux into the native ureters, but
no,
the last one wasn't.
No.
Yeah,
it was no reflux to native.
There was no reflux.
No reflux.
So even now.
Only to the graft.
So yeah, I thought there was originally, but not later on in the life of the child.
Have you done a cystogram?
Yeah, it was on the cystogram. Yeah, we provide him cystogram before the transplantation, and it was no signs of vesicoureteral reflux in native kidney.
So,
Yes, there was the megaureter.
Ureter earlier on, it won't have disappeared. So I'd probably repeat the cystogram, and I think you're probably going to have to take those systems out. And the other thing is to leave him on prophylactic antibiotics, rotating every 3 months.
antibiotics, low dose, continuous, but also deflux procedure to try and reduce the reflux into the transplant kidney. Have you thought of that, or are you able to do that? One of our does it quite a bit on our patients, actually. I don't know if it always works. Sometimes he goes back and repeats it, but it's one more suggestion you can use.
Thank you.
You've heard of deflux?
Yeah.
Any other thoughts? What would you do in Bristol? Sam? That's the best answer. Yeah. Or to a nephrologist.
I was just going to ask, so the thing is that you've basically had Klebsiella do you have that every single urine sample, so he's got asymptomatic bacteria in as well?
Klebsiella was in every culture and in hemoculture in one case.
Okay, and what's his adherence to his catheterization like? No, when he's not, he wasn't originally. Does he actually catheterize? Was that the issue? He micturates as well?
No, he isn't micturating normally through the urethra only.
So it's only, but was he catheterizing? Because I'm just thinking of Nizam's suggestion to go back to that, but was part of the problem the fact that he wasn't adhering to his catheterization?
I am catheterized him every 1 week because he isn't able to provide catheterization every 3 hours.
So we've also sometimes been in the situation where we've irrigated the bladder. So that's one thing you can do either with antibiotics, or there are some new solutions in the market which you can use. But I think I'd agree with Nizam. It sounds like his native kidneys are going to have to come out.
Thank you.
Thank you very much, Steve. Yeah, a tricky case. Is he on any antibiotics in between pyelonephritis or not?
Yes, he is on cotrimoxazole therapy or nitrofurantoin therapy between, but the sensitivity of this
Is
Klebsiella
resistant
for these antibiotics, and we don't have any other option to treat him between the pyelonephritis, and we are afraid now for a 5th attack of pyelonephritis and resistance to meropenem.
Yeah. Also, I would suggest losing some weight as well, of course. And you've checked the technique of drainage of the Mitrofanov, just to make sure he doesn't do it in a way where it's not aseptic, let's say. Those are our thoughts. Oh,
It's a very negativistic patient, and his compliance with the catheterization is very questionable. Yeah, so we do think that he didn't do it properly, and this is what is the solution for him if we will think in future he will not catheterize himself and he will come with further infections, because he is really very negativistic, and it is also his personality which influences the solution of him. Yeah.
thank you.
Hi, thank you. I was just wondering if you've considered reducing the immunosuppression.
Have you cut down the immunosuppression?
No.
No?
We don't change the regime.
To reduce the attack level, yeah.
Very simple, but going back to basics. You haven't told us what his bowels are like, and is he constipated, chronically constipated, or?
Yes, I asked him. I think he is constipated, but he didn't confirm this.
That's going to be the first thing you need to solve. The other thing is, are you going to have to relax that bladder, and rather than augment with Botox? He tried it before, but would that help this time as well?
I heard badly. I'm sorry.
No, I'm just wondering, he's got a very small bladder.
He
He's still got a very small bladder. obviously with only 200 mils, he should be about 500, and whether or not it's worth giving Botox another go.
All right, thank you very much.